When you think about navigation, you probably picture something that's highly predictable,
Mm,
like a two-dimensional map, rigid borders, maybe highways laid down in concrete.
right.
We just expect our paths from point A to point B to stay exactly where they were built.
Mm.
But when you look at the human body specifically, you look at one of the most critical high-traffic intersections in our entire anatomy, like the groin and the upper thigh,
Mm.
that predictability just vanishes.
Oh, absolutely. It's completely dynamic.
Suddenly the map isn't flat anymore. It's this three-dimensional landscape covered by skin, shifting with fat and muscle, changing its geometry every time you take a single step. And the stakes for navigating it correctly aren't just about, avoiding traffic. They
Yeah.
are quite literally a matter of life and death.
Yeah. And that's exactly the reality that clinicians face every single day. We are talking about a region that is just an absolute masterpiece of biological engineering. The packaging of the nerves, the arteries, and veins here is brilliantly efficient, but it is also exceptionally unforgiving. I mean, you make a wrong turn or miscalculate your depth by even a few millimeters, and the consequences are immediate and catastrophic.
Well, welcome to this deep dive. Today, our mission is to decode this incredibly complex anatomical crossroads known as the femoral system.
Yes, and it's quite the maze.
It really is. And we are drawing from an in-depth anatomical guide by Harold Ellis. So for those of you listening, whether you're an insanely curious learner or you're just brushing up on human anatomy, we are skipping the basic biology today. We are jumping straight into the high-stakes reality.
I think that's the best approach, honestly. The anatomy we are unpacking today provides the exact coordinates used in emergency rooms and operating theaters globally. We really have to understand how to read the surface of the body before we can ever hope to understand what actually lies beneath it.
Right, because this isn't just a textbook diagram.
Yeah.
This is the literal map used to perform life-saving vascular surgeries, to fix complex hernias, bypass blocked arteries, and we are going to explore it spatially. So first we're going to map the invisible lines right on the surface of the skin. Then we'll kind of sink deeper into that geometric space known as the femoral triangle.
A very famous triangle.
Right. And we'll follow the main arterial highway down the leg. And finally, we'll look at the brutal realities of how a surgeon actually accesses this vital area without making a fatal error.
It really is a journey from the superficial down to the profound.
So let's start with that surface mapping. I was looking at Ellis's guide, and I was just struck by how it treats the human body like it has, built-in GPS coordinates.
It does, no.
Yeah, and it all starts with one specific anchor point, which is the femoral pulse. But what shocked me was how mathematically precise the text is about finding it. It says it's located exactly halfway between the anterior superior iliac spine, so that bony point on the front of your hip, and the midline of the symphysis pubis. Is it really that perfectly geometric in a living, breathing patient?
Surprisingly, yes, it really is. That midpoint is the fundamental landmark of this entire region. In clinical practice, if you lose your bearings, or say the anatomy is totally distorted by trauma or swelling, you always return to those two bony landmarks.
You just trace the bones.
Exactly. You find the hip bone, you find the pubic bone, and right in the middle you will find that pulse. It's your anchor. And once you have that point, if you lay the patient flat on their back, bend the hip slightly, and rotate the leg outward to sort of stretch the skin, you can project a little map right onto the surface of the thigh.
Wow. And the text mentions drawing a line from that pulse point all the way down to the adductor tubercle, which is that little bony bump you can feel on the upper inside edge of your knee.
Yep, that's the one. On the medial condyle of the femur.
Right. And Ellis says the upper two-thirds of that imaginary line marks the exact course of the femoral artery. But why only the upper two-thirds? Like, where does it go after that?
Well, that's a crucial detail. The artery doesn't just run straight down the front of the leg to the ankle. After traversing that upper two-thirds, it actually dives deep.
Oh, it disappears.
Yeah, it passes backward through a physical gap in this massive muscle called the adductor magnus. It essentially exits the front of the thigh to move behind the knee, at which point we change its name to the popliteal artery. So that surface line is telling you exactly where the artery is vulnerable and accessible before it hides itself deep inside the leg.
Okay, so that line is the highway. But the pulse itself, I kind of like to think of it as the North Star of the groin.
That's a great way to put it.
Because the guide talks about using this finger breadth rule. Basically, once you find the pulse, you just use your own fingers as a compass to locate the other invisible structures.
Yeah, the finger breadth rules are a brilliant piece of clinical shorthand. I mean, they are simple, but incredibly reliable across totally different body types.
All right, so let's walk through it for the listener. You put your finger directly on the pulse. If you move just one finger's breadth laterally, so toward the outside of the hip, you know you're directly over the femoral nerve.
Right.
If you move one finger's breadth medially toward the inside of the groin, you're directly over the femoral vein.
Yeah.
And if you go deep to that pulse, like straight down, you'd hit the psoas major tendon and the actual head of the femur.
It's basically like taking an anatomical core sample.
Yeah. You drill straight down from that exact point on the skin, and you know exactly which layers of tissue and tendon you're going to strike.
That core sample analogy is perfect. And what's fascinating here is that the medial point, that one finger medial to the pulse where the femoral vein sits, is also the exact spot where the superficial venous system, specifically the great saphenous vein, terminates.
Yeah.
It just dives deep right there to dump its blood into the femoral vein. As Ellis notes, because of how often varicose veins are treated, that specific spot might be the most commonly used surface marking in all of vascular surgery.
Wow. Okay, I follow all of that, but I need to stop you on one detail that really threw me.
Sure.
The text says that if you slide your finger from the pulse, proximally so, moving up to sit immediately above the inguinal ligament, your fingertip is now resting over something called the internal or deep inguinal ring.
Yes, the deep ring.
Right. And it claims that if a patient has an indirect inguinal hernia, just pressing your finger right there will control it and keep the intestine from popping out. But if they have a direct inguinal hernia, pressing there does absolutely nothing. Okay, let's unpack this. Why does simply pressing a finger above a ligament distinguish between two entirely different types of hernias?
It's a fantastic question, and it perfectly illustrates why surface anatomy isn't just about, memorizing dots on skin. It's about understanding three-dimensional mechanics.
Right.
You have to really visualize the abdominal wall here. The deep inguinal ring isn't just a random spot on the surface. It is a physical doorway through the transversalis fascia, which is the inner layer of the abdominal wall. It's essentially the entrance ramp to the inguinal canal.
So it's like a pre-existing structural vulnerability.
Exactly. And an indirect hernia is when abdominal contents, like a loop of intestine, enter through that specific pre-existing doorway. And that doorway is physically located right where your finger is pressing, just lateral to the inferior epigastric artery.
Ah.
So if you literally plug that specific entrance ramp with your finger, the indirect hernia just physically cannot come out.
But a direct hernia ignores the doorway completely.
Yes, exactly. A direct hernia is a brute force blowout. It doesn't use the deep ring at all. It just pushes its way directly through a weakness in the abdominal wall muscles further medial to your finger. So plugging the deep ring with your finger won't stop a direct hernia because the intestine is breaking through a completely different part of the wall.
That makes so much sense.
Yeah.
You're just testing which exit the problem is using. It's wild how much diagnostic power a clinician has just by knowing exactly where to apply pressure with a single index finger.
It is the absolute essence of clinical examination. Your hands are actively reading the internal architecture.
Which brings us to the architecture itself. The pulse isn't just floating in a void. It sits tightly packed in this specific high-pressure junction that requires a unique anatomical housing.
Right.
So we need to move from our single surface point into the actual three-dimensional geometric space beneath it. Let's map out the femoral triangle.
The femoral triangle is a beautifully defined compartment. It essentially quarantines and protects all these vital vessels as they transition from the abdomen down into the leg.
Okay, let's draw the borders for the listener. The top of the triangle, the superior border, is the inguinal ligament running across the crease of the groin. The inside boundary, medially, is the medial border of the adductor longus muscle. And the outside boundary, laterally, is the medial border of the sartorius muscle.
And like any architectural space, this triangle has a roof to seal it and a floor to support it.
The roof seems relatively simple.
Oh.
It's skin, superficial fascia, which has some lymph nodes in it, and the deep fascia called the fascia lata. I noticed the guide mentions the deep fascia has a specific hole in it, the saphenous opening. I assume that's just a dedicated trapdoor to let that great saphenous vein we talked about dive down into the deep system.
Exactly. It's a precisely engineered fenestration just for that vein. But the floor is where the heavy structural support comes in. Moving from the outside in so lateral to medial, the floor is paved by four distinct muscles: the iliacus, the
Pectineus, right?
Right, the pectineus, and finally the adductor longus.
Wait, why those specific muscles? If the vessels just need to get down the leg, why do they need this complex muscular bed beneath them?
Well, because you are dealing with a high-pressure, high-volume arterial system traversing a joint that is constantly in motion.
Oh, right, the hip.
Exactly. The hip joint is flexing, extending, bearing the entire weight of the body. If the femoral artery was just resting against hard bone, the constant friction and compression would just destroy the vessel wall. Those forefloor muscles provide a dense, dynamic muscular cushion. They basically act as a shock absorber for the vessels against the rigid pelvis and femur beneath them.
That's brilliant. So they have this muscular mattress beneath them and the fascial roof above them. Here's where it gets really interesting.
Yeah.
Let's talk about the vessels themselves, because they aren't just thrown into this triangle randomly.
Not at all.
They're aligned in a highly specific order, from the inside of the thigh, moving to the outside, so medial to lateral.
Mhm.
It's vein, artery, nerve. Why that exact arrangement? And is there a mental shortcut to remember that?
I'll give you the shortcut first.
Huh.
A lot of people use the acronym VAN, V-A-N. From medial to lateral, it's vein, artery, nerve.
Right, artery, nerve. Okay, that's easy.
Right. But functionally, it's largely about protection and developmental efficiency. The femoral nerve is lateral because it needs to immediately fan out and send branches to the massive muscles on the front and outside of the thigh. It wouldn't make sense for it to be trapped on the medial side.
That makes sense.
And the vein is most medial because as it travels up, it needs to be closest to the midline to efficiently return blood to the inferior vena cava. And the artery, which is the most critical to protect, sits perfectly shielded right in the middle.
So they're perfectly positioned for their jobs.
They are, but you have to remember that anatomy is dynamic. As those structures travel down toward the apex of the triangle where the space gets incredibly narrow, that side-by-side van arrangement actually shifts. The vein, which starts medial to the artery, begins to sort of slip entirely behind it.
Oh, so they are stacking themselves to fit into a tighter tunnel. Which brings us perfectly to the structures leaving the triangle. We need to follow the main arterial highway.
Let's do it.
The text notes that the femoral artery is essentially just a name change from the external iliac artery once it passes under the inguinal ligament. But right at that starting line, the artery and the vein are wrapped in something called the femoral sheath.
Yes, the top 3 to 4 centimeters of the artery and vein are encased in this fibrous sleeve formed by a continuation of the transversalis fascia and fascia iliacus from the abdomen.
But what I found fascinating is that the femoral nerve is left completely outside this protective sleeve. It's just sitting out there laterally. Why would the body wrap the blood vessels but leave the nerve out in the cold?
It all comes back to their different trajectories. As we touched on, the nerve's job in the thigh is to immediately break apart into a dozen different motor and sensory branches to supply the quadriceps and the skin.
Right.
If it were trapped inside a tough, fibrous sheath, it couldn't easily distribute those branches. The artery and vein, however, are commuters. Their primary mission is to travel safely down the leg so they stay bundled in that protective fascial sleeve.
Speaking of commuting, right as the artery enters the thigh, the guide lists a handful of small superficial branches peeling off immediately the superficial epigastric, superficial circumflex iliac, and external pudendal arteries, plus the deep external pudendal. Why is the main artery dumping blood locally right out of the gate instead of saving it for the leg?
Well, those superficial branches are tiny. They exist to supply the immediate local tissue, the skin of the lower abdomen, the superficial fascia, the inguinal lymph nodes, and the external genitalia. They are essentially, paying the local toll before the artery continues its major journey.
Right, but the real star of the show isn't a superficial branch. About 3 centimeters below the inguinal ligament, the femoral artery spawns an absolute giant.
Yes, it does.
The profunda femoris, or the deep femoral artery. It branches off the posterolateral side of the main trunk. And reading the text, I couldn't help but wonder.
Yeah.
So what does this all mean for the human body? If the femoral artery is this massive high-pressure hose supplying the whole lower limb, why does this one artery need to spawn such a massive secondary branch almost immediately after starting its journey in the thigh?
It's a perfect example of how the body delegates cardiovascular workload. What's fascinating here is you can conceptualize the main femoral artery as an express train.
An express train, I
Yeah,
guess.
its primary vital job is long-distance transport. It needs to travel through the subsartorial canal, also known as Hunter's Canal, pass through the adductor hiatus, and get a massive volume of highly oxygenated blood all the way down behind the knee to become the popliteal artery. It does not have the capacity to stop and supply everything along the way.
Oh, wow. So the profunda femoris is the local train.
Precisely. The profunda femoris is not just a branch. It is the principal lifeblood for the massive muscle groups of the thigh itself. Through its circumflex branches and a series of perforating arteries that punch right through the muscle layers, it feeds the quadriceps, the hamstrings, all those huge power-generating structures. It basically takes the enormous metabolic burden of the thigh off the main femoral artery.
It splits the workload. One artery for the local heavy lifting, one for the long-distance transport. But because this massive intersection happens so high up and so close to the surface, it makes the femoral triangle the ultimate access point for surgeons.
It is arguably the most critical exposure site in all of vascular surgery. Whether a surgeon is performing an embolectomy to drag a clot out of the leg, or wiring a catheter up to the heart, or bypassing a blocked vessel, this is where they enter the system.
Right, so let's take this theory into the operating room. The text describes the surgical setup. The patient is lying supine, the leg is abducted, moved away from the midline, and externally rotated at the hip.
Standard exposure.
Right, this stretches the anatomy and brings the triangle to the surface. But earlier, we talked about using the femoral pulse as the ultimate compass. What happens if the patient has a severe blockage and the pulse is just gone?
That is a very common and honestly very stressful reality. If a patient has an occlusion higher up or severe peripheral vascular disease, that pulse might be completely impalpable. You are essentially flying blind.
Which means all that math we talked about earlier, finding the halfway point between the hip bone and the pubic bone, becomes absolutely mandatory. You have to calculate exactly where the artery should be, even if you can't feel a thing.
Exactly. You must trust the rigid, bony landmarks because the soft tissue is lying to you.
And the guide highlights a terrifying pitfall here. A remarkably common surgical mistake is making the initial incision too low in the groin. But if the surface anatomy is so clear-cut, how on earth is starting the incision too low such a common surgical mistake?
This is exactly where anatomical theory collides with clinical reality. In a textbook illustration, a patient is perfectly proportioned. The crease of the groin aligns perfectly with the inguinal ligament. But in a living patient, especially one who is obese, the groin crease is just a fold of skin and adipose tissue. And fat obeys gravity.
Oh, man. So the visible crease sags down the leg.
Yes. The heavy abdominal apron pulls the superficial skin crease dramatically downward, far away from the true inguinal ligament, which, remember, is firmly anchored to the bone. If a surgeon subconsciously follows that visual skin fold and starts their incision there, they're cutting way, way below the actual anatomical landmark.
And if you start too low, you miss the main trunk of the artery entirely.
Exactly.
You'd land below the bifurcation, completely lost in the branches of the profunda femoris, instead of having control of the main express train.
Precisely. You are digging through thigh muscle while the main artery is sitting 3 centimeters above your scalpel. That's why Ellis insists the incision must start above the visual groin crease, directly over the palpable bony ligament. Trust the bones, not the soft tissue folds.
Okay, so assuming the surgeon trusts the bones, they make the correct incision. They navigate the dissection, encounter the great saphenous vein medially, ligate the superficial circumflex iliac branch laterally, open the deep fascial roof, and open the fibrous femoral sheath.
Good technique.
Right, there it is, the main arterial trunk. They snare it, but the guide says the dissection usually isn't over because they often need to access the profunda femoris trench as well.
Yes, controlling the main trunk is really only half the battle. To do a proper bypass or clear a complex clot, you usually need control of the deep branch too, so the surgeon has to dissect downward about 3 centimeters to find it.
And here is the hidden trap. Just as the surgeon is tracking down the side of the artery to find where the profunda branches off, they run into a massive obstacle.
The medial circumflex femoral vein.
Right, the text explicitly warns about this. It's a surprisingly large vein that crosses directly over the femoral artery, exactly where the surgeon is trying to work. If a surgeon is rushing or just expecting a pristine textbook view of the artery, what happens if they tear that crossing vein?
It results in a massive, obscuring hemorrhage right in the deepest, most critical part of the surgical field. It's a perfect example of why you can never memorize arteries in isolation. The venous system is inextricably wrapped around them.
Right.
To get safe access to the deep artery beneath it, that crossing vein must be meticulously identified, tied off, and divided. You basically have to dismantle the venous roadblocks to treat the arterial highway.
It is an incredible high-wire act, and it really brings this entire deep dive full circle. We started by just conceptually placing a single finger on a pulse halfway between two bones. From that one surface coordinate, we explored the architectural boundaries of the femoral triangle, tracked the artery's transition into the leg, and finally understood the brutal, high-stakes precision required to surgically expose it without getting misled by sagging skin or severing hidden veins.
It's a profound journey through a relatively small area of the body. But before we finish, I think it's really worth considering the evolutionary vulnerability of this exact anatomy.
Oh, I'd love your perspective on that.
When you look at the design, it's quite a paradox. We have one of the body's largest, highest pressure arterial highways running incredibly close to the surface of our skin in the groin. There is no rib cage to protect it. There is no thick
It's
skull.
just skin and fascia.
Exactly. It is just shielded by a thin layer of fascia and skin. Now, in the 21st century, that anatomical design makes it wonderfully accessible. It allows us to introduce catheters, deploy stents, and perform bypasses that save millions of lives.
Yeah.
But historically, for the vast majority of human evolution, having a massive artery just millimeters beneath the skin in such a highly mobile, exposed area was an incredibly dangerous flaw. A single puncture wound or laceration there from a predator or a weapon, long before the advent of modern vascular surgery, was almost universally fatal.
Wow.
It is fascinating to realize that one of our greatest modern medical advantages is built directly upon what used to be our ancient, fatal weak point.
That is an incredible way to look at it. Our life-saving access point was literally an evolutionary Achilles heel. Think about that the next time you happen to feel a pulse. We'd love to hear what stood out most to you about this biological engineering marvel. Leave us a comment or a question wherever you're listening to this deep dive, and let us know what part of the surgical map surprised you the most. Till next time, keep exploring.